Okay, everyone, I think we're ready to get started here. So thank you for joining me. It's my pleasure to talk to you about voice-driven virtual assistants. This is something that the team at Modernizing Medicine, where I work, we've been experimenting with and doing a lot of research on over the last year. So I'm excited to share with you some of the progress that we've made and kind of really telling you about kind of our journey through this process. And realizing that this is kind of an emerging topic. This is not something that is I would say ready for prime time. And I'll talk to you kind of a bit about even where I think this technology is going in the space of healthcare. So just a bit about myself. So I am Senior Director of User Experience at Modernizing Medicine. We are an electronic health records company. So we support the entire ecosystem of designing technology for doctors, for nurses, medical assistants, technicians, and even patients. So we're serving a lot of different people. And so I lead our user experience team. So every day we are focusing on user-centered design. How can we improve the lives of the people that we're designing for every day? And voice was something that has been on our long-term radar. And it's something that is something I think that has a lot of potential. And if your team hasn't looked into voice technology for your software, I think the technology now is at a point where it's ready enough to start, having a really good look at what kind of great experiences you can create right now. So I have to say, so my impression of medical technology in the 21st century was, not necessarily flying cars, but I did expect us to be a bit further along than we are. This video shows an example of a typical doctor's situation, maybe an exaggeration, but they are trying to serve their patients. They're dealing with a lot of medical staff, technology. They're on their computers. They're not looking at patients. They're documenting things. And honestly, there's still paper in all of these offices. So my team knew that there's a lot of challenges that remain for us, even though we've come a really long way in healthcare technology. I have to say, I was really amazed by this study that was conducted by the American Medical Association with the University of Wisconsin. I mean, look at how many hours physicians are spending with their electronic health record systems. I mean, it's crazy. They are, and that's why in that video you saw, the doctor's in front of the computer because they have to document every aspect of the medical visit for government regulation purposes, for, in the US, a lot of documentation for health insurance companies that require a lot of extensive information before they'll do reimbursements. And then you have a lot of just administrative tasks, things that go into just operating a medical practice every day, and a whole staff ecosystem as well that the physicians are trying to manage. So physician burnout is something that we have heard a lot about in the last few years. AMA and other organizations have really said it's kind of a chronic illness for physicians. And they do blame medical software as one of the top reasons why doctors consider themselves to be burnt out. And so given that we work for an electronic health records company, especially where we're in user experience, we are trying really hard to find lots of ways to make these experiences better. And I'll say that one thing that I have heard a lot in the healthcare technology industry is making our technology go on a click diet. And if you haven't heard that term, it's something I hear almost every day by our chief medical officer and our own physicians in-house, is that how can we reduce the number of clicks to do all these tasks? How can we save a keystroke? And those are great things, and we do really try to find ways to reduce those things. But in reality, cutting clicks is not, I don't think, going to completely eliminate physician burnout. I think there's a deeper issue of how doctors fundamentally interact with our technology. So, not surprisingly, voice. Voice has huge potential within the healthcare technology space. And we're not exactly paving new ground. I mean, voice is something that a lot of us use every single day. I use my voice to ask Siri, about my calendar for the day, or to read a text message, or to send a text message. We have the Google Assistant, Alexa built into, lots of household things. All of our technologies that we use every day are starting to have voice natively embedded in it. And the technology is getting better every day to be more accurate, to have more capabilities, and hopefully just to have us less, less need to actually directly physically interact with all these technologies, kind of becoming more of an ambient solution to using technology. And so that has also been something that physicians are using too. A lot of doctors already using Google Assistant and Siri in their personal lives. Some of them have started to use it for work-related tasks as well, that same technology. And physicians realize this stuff is here, and it's here to stay, and it's only going to grow. And so you have a lot of organizations that are looking at the evolution of voice within the healthcare world. And so it's something that my team has been looking into. We're very conservative, I think, when it comes to this technology. We want to make sure that technology is safe and reliable, and it creates the best possible experience. So we've done a lot of early research to make sure that we understand the potential for the technology, how it could be used, and we really want to make sure that we get it right before we unleash it on our clients. I will say, though, that the idea of just voice is not new to our clients, and a lot of other electronic health record companies as well. So you have technologies like Dragon Medical One by Nuance. You have Fluency Direct by M-Modal. And we have those technologies that are embedded, as you can see in this screenshot, into our products. And so that's great if a doctor wants to just dictate and have the technology transcribe word for word what they want said. But that's not really allowing them to really have truly like a medical assistant where they have tasks that have to be done. They have schedules, reminders, and medical orders to look up, and medical orders or medications to prescribe. So the technology as being used right now is limited really to just straight dictation. And so while they're used to voice, we know that taking things further where this technology is going to be more pervasive and further incorporated into the doctor's world, we wanted to make sure that was going to really work properly. So we kind of had this vision of the future where, and you'll see this as Emma. Emma is our electronic health record system. It stands for Electronic Medical Assistant. And so Emma is really the persona, if you will, that we've created to, just like Siri, to really embody how a doctor would interact with our technology. And so we tried to think about how would a doctor be talking to Emma? How would Emma talk back to the doctor? How would that dialogue work in hopefully a very seamless way? And a lot of our doctors use different technologies in their ecosystem in our practices. So they're using, as you see in this photo, they're using iPads with our software. They're using iPhones. You'll see an example even of Apple Watch, even in traditional desktop computers. So we wanted to make sure that whatever voice experience we create is going to be compatible with whatever technology that they're already using right now. So, so I want to share with you kind of what our journey has been so far. This is an evolution. I can tell you right now, we are still in the proof of concept and prototyping stage. We have spent a lot of time doing user research, which I'll talk to you about in a moment. We've created prototypes. We've shared them with clients. We've had some chances to iterate and improve on it. And we're sort of keeping open minds as this technology evolves. And if you Google this technology right now, you'll see that there are already a lot of partnerships out there. Companies like big companies like electronic health record companies like Epic or Cerner. Sorry, that's my dog barking. Are using this technology already. So we want to make sure when we talk about kind of the advantages of using this technology, realizing that they already have ways to document visit notes. They already have ways to e-prescribe. what can we do to actually reduce the manual data entry that's happening? We're doing that a little bit with straight dictation, which is great. But there's a lot of activities that happen that dictation doesn't handle. And it requires doctors to do quite a bit of typing and quite a bit of clicking. So we want to see if voice could kind of replace a lot of those things. There's a lot of preparation that happens just to see patients every day and kind of know what their schedules are like, what are patients coming in for, what tasks have been done to prepare the room for the patient. There's a lot of activities that are happening throughout the workflow. I'll share with you actually a journey map that we created to sort of look at the entire experience that the doctor has day in, day out. Where can we actually make that process less painful? And then, and ultimately, this is really our end goal here. I mean, we are trying to help doctors so that way they can help their patients and ultimately improve their healthcare. We don't want technology to be in the way. So if we're going to introduce a virtual medical assistant, we have to make sure that this is not a barrier, but actually an enhancement to what the doctors are ultimately trying to accomplish. And then, like I mentioned, we were trying to understand this with a proof of concept. And so we had some questions we wanted to make sure we could have answered by this process. And so, ultimately, is this something that a doctor is going to want to actually use? Is this something that they are going to be receptive to? They're familiar with voice, but do they really want kind of technology being more kind of embedded in their medical practices? And and are they going to be able to envision this improving their current workflows? So are they going to have to change how they do certain things? Are they going to have to do workarounds of things that they're not used to doing? And then also just using voice in more of a command and task-oriented environment. Is it easy to use? Is it something that is natural, that follows their mental models, or are they going to have to train or relearn processes that they're already doing right now? So as I mentioned, we did a lot of user research to kind of support this initiative. I'll share with you just a few of the highlights. Contextual inquiries are something that my team does a lot. We try to go out in the field, visit doctors' offices as much as we can. And so as part of this initiative, we went to practices to understand their workflows, to understand, like I said, there's a lot of different technologies that they're using day in, day out with our software as well as other software and hardware that they're using. And you can see just in these photos that there's so many different environmental factors we had to think about when it comes to voice. Things we learned include these are noisy environments. Sometimes they're private. So you can see that the doctor in the bottom left is in his office with the door closed, and that's great. It's a nice, quiet environment. Not going to be a lot of issues with the system hearing them properly. You can see in a lot of other photos here, they're kind of out and about. They are in shared workspaces. Sometimes they're not even in a workspace. Sometimes they're standing up in a hallway, and sometimes they're not even at the computer. You can see in the top right corner here, we have someone that's actually treating a patient, and so they're not facing the desktop. They're not sitting there. And so, can we introduce something like a smart speaker where they don't even have to be in front of the technology? So, a lot of opportunities for voice, a lot of challenges, but this was a really eye-opening experience to kind of understand, what challenges we were going to face as we developed our proof of concept. And then what we did is we really wanted to involve clinicians and their staff in the design process. And so we have a big annual users conference, and at Momentum, we do design labs every year. And design labs are basically a fancy term for participatory design sessions. So these are sessions where my UX team kind of moderates sessions with our clients where we go through a process to kind of understand their needs. We follow what's called sort of a traditional double diamond approach, where we really want them to come. We wanted them to come up with as many ideas as they could. So we said, if you were to have kind of this virtual voice-based assistant, what would you want it to do? So people had lots of ideas, and then what we did is we had people vote on the things they thought were going to be most valuable to them, and to help prioritize what those top 5 or so were. And then the next part of the double diamond is really having to think about, okay, you want it to refill prescriptions for you, or tell you about different parts of the patient's chart, or have you check on lab results. Great. Well, how do you want that to work? How would you want to interact with the system? And so they came out with a lot of interesting workflows of how they would expect to talk to the system, what they would say, what they would expect the system to do. And so it's really interesting to sort of see, clinicians and medical staff kind of really think outside the box. This is not something I think they were very used to doing, and certainly nothing in sort of voice and how that would be, because it was something new for their practice, how that would work. But they were very creative. We came out with a lot of interesting ideas that, and there were more than this, but really kind of top 5 things that we saw based on our DesignLab sessions, as well as the contextual inquiries we did. These were the common things that people wanted a VMA to be able to do. So things related to patient scheduling and agendas. They wanted to know, what does my schedule look like? What kind of patients am I going to see today? What are some of the important things I needed to know about the patients that are coming in? And of course, who's my next patient? So basically understanding kind of how their day is going to look, and what how the system kind of gives them the information they need contextually about the people that they're going to be seeing. And a lot of information about the patient. So, do they have allergies? Do they have certain lab results that I need to know about? And what were the results of those labs? While they're seeing patients or immediately after, they have a lot of, as I mentioned earlier, a lot of documentation that is involved with documenting the patient's chief complaint, understanding, what procedures were done, what are the follow-ups that have to happen with that patient. And then if there are necessary edits that have to be made to that note, they want to be able to quickly make those without having to be disrupted. A lot of tasks have to happen, like I said, with labs and reports and results, being able to look those things up, being able to follow up on those, being able to act on them. And a lot of delegation happens as well. So they want to be able to assign quick tasks for other staff members to do. Maybe they want to tell a medical assistant to bring this patient to have an X-ray done or an MRI, or maybe they want to make sure that someone calls that patient with results from their procedure tomorrow. So quick ways where voice could kind of be kind of their right hand assistant there. And as I mentioned, so we did a journey map, which is something that we do for a lot of our different roles that we have at Modern Study Medicine. This is Oscar, or orthopedist persona. So we want to see, if we were to introduce voice into Oscar's world, what would that look like? And I know this is hard to see because it's a really big journey. But the important things here to note is that we want to see how voice would play into before Oscar even got into the office. What is he doing to prepare for his patients? What is he doing while he's seeing patients? And then what happens after he has seen that patient? And so it's kind of the end-to-end journey. Obviously, this repeats and is a spectrum of time. And you'll also notice there's a lot of activities that are happening, and you probably can't read it there, but they are color-coded in that we wanted to see what actions is Oscar taking, and what is the dialogue that he would have with Emma, his virtual assistant. And so the areas in blue are where Oscar is talking to Emma, what Emma is doing in response to what Oscar is saying, and then any kind of information that Emma would be speaking back to the doctor. So you'll see that, well, you probably can't see as easily here. Sometimes these things are taking place on Oscar's iPhone, maybe while he's driving into the office, or preparing for a patient and he is talking to Emma via his Apple Watch. Or it could be desktop-based as well, maybe where Oscar wants to be able to view X-rays on a larger screen. Or it could be a dialogue that's happening with the patient where he's not in front of any screen, he's treating the patient, and a smart speaker is actually being used to interact with Emma in that case. So a lot of different technologies that Oscar's playing with here. And the dialogue, it's not a one-way street here. The point here also is that, Oscar is talking to Emma, but Emma is talking back and providing information, asking for clarification, and even alerting Oscar proactively. So for example, if Oscar is going to be seeing a patient that has a serious allergy, Emma could proactively vocalize that to the doctor instead of him having to look that information up. So our journey was something that was really important to establish early on. So we kind of knew, okay, this is cool technology, but where's it going to fit into Oscar's world in the context? And this was kind of the framework for all the things I'm going to show you now about how we went into designing task flows that ultimately made their way into a prototype. So how do we actually go about designing this thing? Well, like I said, so a task flow was one of the first things that we kind of had to figure out. We had to think about, and we really extracted a lot of this from the journey, is given the task we know people want to do. So maybe checking and responding to emails, tasks related to filling prescriptions, and tasks related to scheduling. So you can see here just a sample of some of the workflows that we worked on. And you can see also, like, the journey is color-coded to show what is the doctor saying, how is Emma responding, what is happening. And given how the interactions and dialogue are happening, sometimes there are branches in the conversation as well. And for the proof of concept, we tried to keep things pretty simple, although it ended up being, we had to constantly go back and sort of simplify things because there's a lot of potential avenues and different paths you could take in a conversation. For the proof of concept, we tried to keep things pretty simple and straightforward. And then we had to think about, well, how are we going to create this prototype? We do a lot of prototyping for design work at Modernizing Medicine. We use tools like Envision pretty commonly with Sketch, and we found that was not going to do it. We wanted something that we could prototype that would actually simulate the interactions that a physician would have. And so we wanted Emma to actually speak. We wanted people to actually speak to Emma. And so this was a time when Adobe XD had just released their ability to do voice-based prototypes. And so this was pretty early on. This is a screenshot from Adobe XD where you can see that I highlighted kind of just one interaction point where you can see that voice is labeled as the trigger. And so that's basically telling the prototype. And also, we didn't want to have to code all this from scratch. We didn't have development resources for this. This was a project that UX had to do. So that's why Adobe XD was really the best fit, because we didn't have to do any programming to make all these interactions happen. So you'll see that there's a command that the prototype is listening for. The good news is that the prototype is pretty flexible. So even if someone didn't say the exact words or phrase, if they're close enough, the prototype would trigger the right response. And we had a lot of flexibility in terms of when voice could be triggered, but there also were a lot of limitations as well. So if you use Adobe XD for voice prototypes, because it's not a true Alexa, it's not a true Siri, there are limitations. And so to trigger a voice response, to have the computer listen for a voice response, you had to either hold down a key while you spoke, or if it's an iPad-based one, you got to press and hold a certain button on the screen. That's not how it would work in the real world. We would want it to be kind of a wake word like, hey Siri or hey Emma to trigger the response. But for our prototype, we had to have it be something where someone had to hold something down while a command was spoken. And you can see here, this is the sampling of the screens and all the mock-ups that we had to create for the voice prototype. All these screens were all wired up, so that way any action that the user took would be directly connected with the voice, both in terms of what information is displayed on the screen. So a lot of these triggered events happen on the screen as well as being verbal. And then also you'll see in an example in a moment, you'll see that we have on-screen prompts as well. And this is sort of a safety check, if you will, to make sure that it was clear the system responded correctly to what the person wanted, so they can listen for the response, but they could also see the response on the screen as well. And then really to kind of bring all this to light, because this was very new for us, it was new for our stakeholders, for our executives to say, okay, well, how is this whole voice thing going to really work, like inside of a practice? I mean, we did show them the journey map, which is great, but the journey map's kind of abstract. And so we kind of went above and beyond, and we actually had our in-house video team. We went to an actual practice, and we came up with this video shoot that we called Practice of the Future. And so we used our virtual medical assistant, as well as a bunch of other new technologies that we saw were on the forefront of the healthcare space. And we wanted to kind of simulate what that would be like in an actual medical practice. So I'm going to share with you just a short video clip from that Practice of the Future concept, just so you can kind of see where voice fit into our system here. So you can see it. We have our smart speaker, where the doctor was commanding for a procedural video to display on the wall. The doctor had a successful visit. Now she's spending a bit of time documenting part of that visit. And again, you can see some of the on-screen information, as well as Emma would be speaking this information. Again, part of the ecosystem, being able to have the doctor use her Apple Watch if she's out in the hallway, not in front of a computer. She wants to do a quick follow-up with the patient. Takes just a few moments to do that. And so you can get kind of a taste of where this is going, but it really helped us kind of envision, how all this would work as things transcribed. We also wanted to bring this to our clients, and so I mentioned Momentum, which is our big annual users conference. So we actually had Practice of the Future as a full kind of museum style exhibition. And so we had different booths where next generation technology was being showcased. And so we had, within the doctor's exam room exhibit, we had Emma, our virtual medical assistant, on display where people could actually interact with it. So we had there's Mick from our UX team, actually was showing clinicians how the voice system would work and demonstrating it. And we kind of got some really good feedback about, and a lot of good questions about how this would work. I will say that people were excited for the technology. I think they saw a lot of potential for it. A lot of them told us they're already using Dragon and other technologies to do dictation, so they kind of saw this as like a natural extension of that technology. So it's really great to kind of hear from clients and have them be able to try this stuff out before we even really actually built it. And lastly, I want to leave you with just sort of lessons learned that we had in this process. There were a lot. I'll just boil it down sort of 4 sort of key areas, and these were big considerations. Patient privacy. So as you can imagine, all the environments where the doctor or the medical staff would be interacting with Emma and speaking to Emma and having it speak back. These are in areas where sometimes they're in public areas. In the US, we have HIPAA compliance, where we really make sure that we keep patients' privacy intact. And so that's really hard, because Emma has to know which patient to prescribe the medication to, what are they being prescribed for, which patient has a certain medical diagnosis. And so that gets a little tricky if you're doing that stuff in an area where people that shouldn't be hearing that information may hear it. So that introduced a lot of challenges there. Patient safety was also a major concern. So if you're using voice is not perfect. And so we want to make sure that if a doctor is prescribing a certain medication, that the system repeats that information back, as well as displaying that information on screen. And so it was really important that we didn't introduce new patient safety issues where voice was being used. Context of use was super important. We learned this during our contextual inquiries, that people are going to be using this in all different environments. Some very noisy environments, using different technologies that have strengths and weaknesses. So the sensitivity of the microphone, noise cancellation, thinking about how close people are to the actual microphones was really important. And then finally, but certainly not last, is learnability. We wanted to make sure that we're not introducing more physician burdens contributing to burnout. And so doctors really did not want to learn a lot of new things. They wanted us to be using natural language. They didn't want to have to learn how the computer wanted things to be said. They didn't want to have to repeat things 10 times. They didn't want to have to introduce new workflows or new ways of working. They wanted the technology to kind of blend into how they currently work. And then lastly, as we're looking to the future here, we have made progress. I mean, I think that, voice to text dictation has matured to be pretty accurate for most users. We've already been doing a lot of voice-driven actions for certain tasks. And really, I think we're at the point where natural language processing and a bit of contextual understanding is at play with some of the newer technologies where we can do tasks and have doctors do things without having to learn how the computer wants to do it. They can use their own words. And the technology is capable in a limited way of learning and understanding the doctor and kind of evolving a bit. And where this is all going eventually is really what they call ambient intelligence, where the computer or the technology is constantly listening behind the scenes, where you have microphones that are built into exam rooms, and where it is constantly listening for the dialogue between the doctor and the patient and documenting things behind the scenes. And so really that's a future where technology is truly in the background and is a lot smarter than where it is right now. We're not there yet. There are some companies that are working on it. But I think that the stuff that we developed with our proof of concept is more of this middle layer, I think, of where natural language processing is now and where it likely will be for the next few years. And so we're trying to look within kind of the next 3 to 5 years where voice-driven assistance will be hopefully part of our clinicians' experience in the near future. So I know I covered a lot of things in a short period of time. Thanks for giving your attention today. I think we have time for maybe a few questions, if there are any, or feedback would be great as well. If any of you are doing this technology in-house right now or have experimented with it, I'd love to hear what you have been doing.
Okay, great stuff. Thank you so much, Andrew. Really appreciate it. It was really great. And there's 3 questions that popped up. One that pops up for me really quickly before I address the questions is just addressing where patients have maybe a problem with dialect or disabilities, and how voice would actually, combat that or help that, because I mean that's obviously something where machine learning comes in. So I mean, just what's your thoughts on that?
Yeah, that's a good point. So that is still definitely a challenge for the technology. It's getting better every day as they really train these systems and as the databases get larger and as they expose the voice-driven systems to different dialects, different accents, and different ways of saying things. It is getting better. It is definitely still something that is challenging because doctors, even if the technology works 90% of the time, that's not always acceptable to them. They want it to be working like 99.9% of the time accurately.
Okay, super. So so let's just do the question. I mean, the first question we have is, does interoperability across platforms have sort of legal implications, and how do you overcome that, or is that something you guys are looking at?
Well, so interoperability. So we deal with interoperability quite a bit at Mars Link Medicine. I mean, I think it's going to introduce new challenges if we're going to be having tasks that are accomplished with voice across different systems. We have not gotten that far in terms of our voice system. I think right now we're thinking of constraining it just within the EMMA ecosystem, our system right now, and perfecting that before exposing it to other systems.
Okay. So the next question we have here is, do you run into any sort of PHI concerns when developing EMA? In addition, what is the accuracy threshold that virtual assistant needs to reach to foster sufficient user trust?
Yeah, PHI, as I mentioned, that's a really big concern, and I think that it's going to be a hybrid solution. I think that doctors and clinicians and anyone who might use the software has to be aware of where they are using the system to some extent. So, if they are in a public space, they should already know that they shouldn't be exposing patient information, either written or verbally. However, I think the system should also have safeguards as well. So perhaps, and I don't think the technology is there yet, but if the technology is able to detect where the user is. So we've been exploring ideas of Bluetooth-based beacons, so the system can know, am I in a hallway? Am I in my office? Am I in an exam room? And so that might introduce more safeguards or prompts for the doctor to say, hey, you might be in a public area, be careful of what you're telling Emma at that time. But it is something that's a sort of shared responsibility, I would say.
Thank you for that. I think you've already touched on this, the answer for this question as well is, and this is from Andy Morris. How have you been managing how patients feel about their privacy concerns? A lot of people are very apprehensive about having microphones and recordings being used in malicious ways. So that's a massive question.
Yes, very good point. Yes, actually, we've explored that a little bit. Yes, we have found that there are mixed reactions. Some patients are definitely concerned about it. Others are okay with it as long as they understand how that will be used. And that seems to be more the case, is that if the patients understand, okay, if the system is constantly listening to to information about me, or if I'm describing it, my illness to the doctor, and this machine is listening and taking notes about it, how are those recordings going to be used? So I think a lot of it was, as long as patients understand how this will be used, many of them will be okay with it. But we also have to understand that there will be patients that are not going to be okay with this, and there has to be an easy way for the doctor to go back to using more traditional means as well. Okay, excellent. So I think we're going to take just the last 3 questions. So I think this is, Ash is asking, so how far along are you with development of EMA, and what NLP transcriptions, text-to-speech services are you using? Mm-hmm. So Emma has actually existed for about 10 years. And so we've been able to evolve it for a fairly long period of time. And a lot of that has been on the iPad as well as web, and to some extent iPhone. The voice stuff is newer for us, I will say. And the technologies that we are using right now are from Nuance. So we use their Dragon medical technology, and that works fairly well. We find that a lot of our doctors are using it. We also support M-Modal, which is, I think, based with their Fluency Direct product. And so both of those technologies have been around a very long time and have evolved. And so we found that our doctors find those very reliable. Okay. And Sarah would like to know, is just, you received a lot of feedback from clinicians. Were you able to get feedback from patients on how this could impact their patient experience? So we talked to clinicians about perceptions of patients. We didn't do extensive research with patients. We did do some, but most of the effort was focused on clinicians and their staff. So we don't really have a lot of information about patients. Like I mentioned, the concern of privacy and how their information reused was the top concern, but we don't have extensive patient reactions at this point. Okay. And Ulysses wants to know, can you share about how lag was received or perceived? Sorry, what was that again? Can you share about how lag was received or perceived? So I'm assuming that. You said lag? Yeah. I'm not exactly sure what they mean by that question. Yeah, neither.
So yeah, that's pretty much it. I think Rihan also had I don't know if it was a statement or a question, but our biggest issue working voice has been making it context aware to the clinician scenario without explicitly asking for that context. So I don't know if that's a question or a statement.
I would say it is all I can say is it is a challenge. Like I said, we've only developed a proof of concept right now. I think that as we start to develop the technology, that is going to be one of the major challenge considerations, is the context of what the doctor is doing and for the system to understand that, both for reasons for learnability as well as efficiency. I mean, the doctor doesn't want to have to always tell them which patient I'm currently referring to or which patient I'm seeing right now. The system should already know what patient I'm currently seeing.
Okay, great stuff. Interesting questions. Thank you very much to everyone who listened, and really good questions. I just want to finish on this, and I thought which is very interesting is that you don't have any developers working on this. You completely use the platform from Adobe. Is that correct?
That is completely correct. Yes, that was one of the constraints of the project. Was we wanted to have a very robust prototype, but we couldn't do it with developers. So Adobe XD proved to be a pretty good tool for what we wanted to show.
Perfect. Perfect. Sounds like you dodged the bullet there with working with developers. Oh, just kidding. Kidding. I know there's a few developers listening here. Okay. Thank you so much, guys. I really appreciate it. Andrew, thank you so much for taking out of your time out of sunny Florida.
Great. Thank you, everyone.
Super.